webinar. I know that today's topic might bring up a number of questions from you. So you may type your questions in chat box and I want to let you know that we will address as many as we can in the time we have today. And I welcome and request our NBMS National Webinar Coordinator, Professor Dr. Somashekhar, to start this session. Welcome, sir. Over to you.
Thank you very much, Navneet Singh ji. So, dear trainees, congratulations. All of you, most of you have passed and cleared the exams. So, now the new batch is just going to join shortly. And now we have about next 6 months before the next practical and theory exam starts. So, it's a time to now spend time more on building up the knowledge and going to didactic talks and the more research topics. As you are aware, in almost last 1 year, the entire endometrial cancer treatment has a huge paradigm shift. Initially it was very simple. I remember when I was in Mayo Clinic, it was very simple. Endometrial cancer, less than 2 centimeter, more than 2 centimeter. If you go grade 3 or grade 1, grade 2, and then myometrial invasion less than 50%, more than 50%. 3 parameters almost solved all the problem about lymphadenectomy. Then if lymph nodes positive, then patient needs chemotherapy, radiation. Lymph node negative, you have done a systematic pelvic paraotic high lymph node dissection, just a walled brachytherapy and observation. Things were very simple. But now you know that the research actually went on for last 1 to 2 decades to bring about the molecular classification and the prognostic factor and molecular factors and genomic analysis into the management. But since last 1 year, all the guidelines have changed. So lot of articles, if you see, every day are published on validation of the molecular classification of endometrial cancer into type 1, type 2, type 3, type 4 different. Not the old type of endometrial cancer classification, simply as type 1, type 2, where you are obese, not obese, postmenopausal, thin lady, then node positive, node negative, high grade muscle invasive. That's why I thought it's apt that for our surgical oncology students, I summarize and analyze how things have changed and what is the way to take it forward for us to go ahead. So it is very complicated topic. Even to understand and read, it took me to read about 10 to 20 landmark articles and publications, and to assimilate and put it into nutshell small, because it's very easy to get confused. Even lot of my senior most colleague who practice exclusive gynae-onco and medical oncologists who practice gynae-onco find it tough to understand and assimilate. So it's a tough topic. No harm if you don't understand it one time, but however, it's very important to understand the basics and gist. I've tried to simplify it as much as possible, yet maintaining all the references, impact, and evidence-based option for you to go ahead and then do. Now, although endometrial cancer is generally considered a very good prognosis, you know why it is considered good prognosis? Unlike cervical cancer, you must understand the main difference between the endometrial cancer and cervical cancer. Cervical cancer doesn't have much of signs and symptoms early. They usually come as a watery discharge almost when they are in stage 3. They don't have much symptom, because watery discharge, most of the people think, okay, white discharge or vagina is okay, normal, I have some infection, and woman is little bit uncomfortable to present or tell and shy. So cervical cancer, 2/3 come in advance, stage 2B or 3, sometime 4A. Endometrial cancer usually is in postmenopausal. However, there is a distinct group of patients when it could be in very premenopausal. So once a menopause has been achieved, any drop of one postmenopausal bleeding, woman is alerted. She knows it is not normal. And especially, whole life she's gone through a menstrual cycle, and now menopause has achieved, it's relaxing, and then suddenly blood comes, they're worried. So they come running. So postmenopausal bleeding is not normal. Unless otherwise proved, all the postmenopausal bleeding needs to be investigated. Unless otherwise proved, postmenopausal bleeding is a atypical hyperplasia or a endometrial cancer. Even any postmenopausal bleeding cannot be ignored. So endometrial cancer women come early because postmenopausal bleeding presents and they come down. Cervical cancer, until they go to advance, the triad of bilateral fixed lymphedema and then venous edema, fixed sciatica pain, and then bilateral hydroureter hydronephrosis relating to uremia, women don't come. That's why cervical cancer 2/3 advanced, endometrial cancer 2/3 75% early. Beauty is old type of classification, type 1, type 2, type 1, obese, hypertensive, diabetic, ER positive, hormone receptor positive, estrogen sensitive endometrial cancer, less chance of biometrial invasion, lower grades, grade 1, grade 2 FIGO, and less chance of lymph node involvement, very good prognosis. Type 1 constitutes two-thirds of even the two-third presentation. So if you see that two-thirds is early stage 1 in endometrial cancer, of them two-thirds are good prognostic type 1. That's why endometrial cancer has a very good prognosis, unlike cervical cancer where most of them come with advanced. So generally it is thought to be good prognosis. But however, remember, the problem in endometrial cancer treatment is we overtreat the low risk. How? There is a low risk, less than 2 centimeter, no myometrial invasion or less than 50% myometrial invasion. And then, FIGO grade 1, 2, we become heroic and start doing pelvic lymphadenectomy, parietal lymphadenectomy, and we overtreat. Or you have done a simple hysterectomy, which is the most common way. Gynecologist would just put a laparoscope, remove the uterus. Oh, sorry, postmenopausal bleeding. Never operate without endometrial biopsy before, or have a frozen section in your setup so you can do one setup. Otherwise, you end up with a laparoscopic hysterectomy or a simple hysterectomy, and then the final histopathology is endometrial cancer. So we end up in an unfortunate area, which is very, very, very sad for us. So what we do, we send them for radiation. Remember, they could be low risk, less than 2 centimeter, less than 50% myometrial invasion, early grade, no lymph node involvement or lymphadenectomy is required. We overtreat it. So we overtreat the low risk by doing unnecessary lymphadenectomy or giving unnecessary radiation without any benefit. Remember, there are two things in pelvis which most of the surgical onco students don't know. Radiotherapy in endometrial cancer has no overall survival benefit. It is only control of locoregional recurrence. Disease-free interval, locoregional, it has an impact on the locoregional recurrence, but not on overall survival. How many of you also know that in rectal cancer, radiotherapy doesn't give overall survival benefit? We all think that, TNT protocol, neoadjuvant concomitant chemo RT, short course RT, we must have imbibed that, radiation gives overall survival. No. Even in rectal cancer, surgery gives overall survival. Chemotherapy, when indicated, gives overall survival, but radiotherapy has only locoregional impact on the locoregional control and DFS, not on OS. So, no use giving overtreating by radiation if it is not going to be required in early. So, endometrial cancer, early we overtreat by doing unwanted lymphadenectomy, unwanted radiation without a benefit. When it is a high risk, suppose it is a higher grade, FIGO grade 3, more than 50% muscle invasion, we don't do lymphadenectomy, pelvic paraotic when indicated, or we don't assess the paraotic lymph node involvement. Even if one paraotic node is positive, it becomes stage 3C. Whatever be the uterine factor, how much ever early it look, and they all need chemotherapy, which is going to give a survival benefit in endometrial cancer. Because remember, surgery gives, chemo when indicated gives, but not radiation. So that's why high risk tumors, we just do hysterectomy, or we do only pelvic assessment. We don't assess the paraotic nodes. If you don't have sentinel lymph node with ICG firefly or whatever, you don't look at the paraotic. Remember, 29% to 30% of the time paraotic node is positive in endometrial cancer because they directly spread to them. When pelvic node is positive, 73% as per the Mayo Clinic data, and also the paper which I published, almost 69% as paraotic node positive. So if you assess the pelvic node by either sentinel node, or if you don't have a sentinel node, you have done a lymphadenectomy and they come negative, don't feel happy. You missed the paraotic that could have been stage 3, which required chemo. So if you just do pelvic node assessment in high risk and it comes negative, you would think it as stage 1 and you would think, oh no, chemo required, maybe radiation not required. You undertreated them when paraotic, isolated paraotic involvement is 4%. And when pelvic node is involved, 69% to 73 paraotic is involved. And if you don't assess them, stage 3 is missed where chemo is required. So, so we undertreat the high risk by not giving chemo, not doing adequate staging, not assessing the paraotic SLNBs. And we overtreat low risk by unwanted doing lymphadenectomy and giving radiation. So this is very important to understand. So the aim is to accurately prognosis, because in endometrial 2 spectrum. One is 2/3 is low risk, No lymphadenectomy required, no radiation, no chemo required. One third is high risk. If you assess them properly, they would need chemo and probably EBRT based on the node positivity site and rate. So you have to prognosticate so that you don't overtreat low risk and you don't undertreat the high risk. While we say endometrial cancer has very good prognosis, it applies only to low risk, not to high risk. Remember, two-thirds of the patient of high risk, if inadequately treated, will fail and recur, and one-third of high risk endometrial cancer, in spite of adequate treatment, will recur. So you understand that it is not so easy. So patients of endometrial cancer originally are prognosticated before an era of NGS, next generation sequencing, genomic profiling, molecular profiling, based on the tumor type. Endometrioid, non-endometrioid. Most common is endometrioid carcinoma of the uterus. Very good prognosis. Non-endometrioid, uterine papillary serous carcinosarcoma or MMMT, mixed Mullerine malignant tumor, carcinosarcoma, metaplastic carcinomas components, and clear cell carcinoma and serous carcinoma. These are bad prognostic marker. They spread like ovarian cancer. They are staged and treated like ovarian cancer usually. And in case of clear cell carcinoma, the traditional chemo paclitaxel is not very useful. People think that you should go based on a oxaliplatin like a colorectal profile, like what 21% of malignancies in Japan are clear cell, but in India it is less than 3 to 5%. So tumor type and grade is important. FIGO grade 3 bad, grade 1, grade 2 good. Now initially grade 1, grade 2 was clubbed into one. Now grade 2 also has come into intermediate grading or little high intermediate grading. Then grouping, what stage is it? Initially we had stage 1A, B1, B2. Now it is not like that, A1, A2, B, no. Now it is A and B. But with the new molecular profiling and the new astro guideline, any myometrial invasion with P53 positive, any myometrial invasion with MSI, that is a, if you have a microsatellite instability, now is grouped into different area. Probably we may have to revisit the old classification. And then age of the patient, BMI, and stage and lymphovascular space invasion are the original factors. Now the molecular classification of endometrial cancer is emerging from Cancer Genomic Atlas. Remember this if you ask anybody, TCGA, the Cancer Genomic Atlas study is the one which provided additional potentially superior prognostic information, and this classifies the whole thing and replace the whole clinico-pathological. Remember, endometrial cancer, then cervical cancer and vulval cancer are staged surgically staged disease. Cervical cancer originally was clinically staged disease. Cervical cancer originally clinically staged. Ovarian cancer, vulval cancer, and endometrial surgically staged disease. Surgery is the mainstay of treatment, and surgery, after you do surgery, is the main staging. But vaginal cancer and cervical was initially clinically staged, but now with the new FIGO modification, PET scan, MRI included, it is also slowly moving from clinical alone to investigation also staging. So while the tumor typing grading supersedes the classification based on underlying genomic abnormality, accurate assessment of pathological parameters are key for patient management. These are depth of myometrial invasion. The moment you have more than 50% myometrial invasion, it gains access to lymphatic space. Lymph node involvement is very high. Cervical involvement. Remember, it is not superficial, deep cervical stromal invasion that makes it stage 2 or extension into vagina, or it has come up to the surface of the uterus. Extrauterine involvement, adnexal involvement, tubes and ovary, and parametrial involvement after having invaded the cervix. These are some of the independent markers of the stage in addition to lymphovascular space invasion. Now, if you look back the current basis until the genomic profiling came, based on the ESMO, ESGO, NCCN criteria, you stratify them into low, intermediate, high risk based on clinical age, morbidity, fertility. Pathological stage, FIGO grade, and then tumor type, as I told you, endometrioid, non-endometrioid, and other variety, and lymphovascular space invasion, which is very important. Morphologically, we have endometrioid, then other is mucinous, serous carcinoma, clear cell, new small cell neuroendocrine tumor, very aggressive, large cell neuroendocrine carcinoma, and then mixed cell undifferentiated, dedifferentiated metaplastic. So now the current risk stratification before the era of molecular is grade 1, grade 2, less than 50% myometrial invasion, no LVSI is counted as low. What is intermediate? Grade 1, grade 2, more than 50% muscle invasion, node negative, and no lymphovascular space invasion, intermediate. High intermediate is there is a lymphovascular space invasion, but FIGO grade 3. FIGO grade 3 is a very high marker of lymph node involvement, peritoneal involvement, cytology being positive. Remember, cytology in itself doesn't change the stage, but its information helps you in conjunction with other factor to decide, but it doesn't change the stage as of today. And high means grade 3, more than 50% muscle invasion, and all stage 2, all node positives are, and non-endometrioid histopathologies fall into the high grade. So this is the current classification of low, intermediate, high. But factors influencing the planning is imaging, tumor profiling, immunohistochemistry, receptor status, hormone negative bad, hormone positive good, MMR status. Remember, MSI, MMR. One is identified on immunohistochemistry, the other one is identified by a next generation sequencing genomic profiling. Both reflect the counterpart of it. Whether proficient or non-proficient, stable or unstable, and molecular profiling. So the whole assessment by Bochman's subtype classification. Bochman's classification initially was very simple. Type 1, type 2. What is type 1? Metabolically involved. We know that other than the ovaries, in postmenopausal women, adrenal gland and the peripheral fat is the source of the estrogen. There is an enzyme called as aryl sulfatase, which converts peripherally in the fat of the breast, fat, abdomen, high dose of estrogen. That's why a obese postmenopausal lady, in spite of ovary not working, can have a high dose of estrogen, which can result in endometrial cancer and breast cancer. So they also manifest with obesity, hyperlipidemia, hyperglycemia, increased estrogen concentration. Type 2 usually is not hormone dependent. Usually type 1 present with low grade, type 2 present with high grade. Type 1 is hormone receptor positive, type 2 is hormone receptor negative. Type 1 is good prognosis, so they are endometrioid variety. Type 2 could be serous or clear cell. Genomic instability is usually less frequent in type 1, more in type 2. P53 mutation, very important. P53 present in endometrial cancer is very worst prognosis. All of them, irrespective of stage and grade, would need chemotherapy, radiotherapy. They do very badly. It is not there usually in type 1. Type 2 it is there. Prognosis very good. 5-year, 85% cure in type 1, whereas poor, half of them are dead. 50% of them are dead in type 2. So this is a Bochman's classification you must know. Now we will read about what is a landmark paper based on that, which was published in Annals of Oncology in 2016. Okay, in 2016, risk stratification, this was published. Low, as I told you, 1A, grade 1, 2, LVSI negative, intermediate, high, and high, intermediate, and high. This was there, which predicted the lymph node metastasis. The problem with this classification, myometrial invasion and FIGO grade has high inter-observer variation. From pathologist to pathologist, it varies. Remember, preoperative endometrial DNC is not adequate to assess the FIGO grade. If it is in the final histopathology FIGO grade 1, there is a 15% disparity between the preoperative DNC and the final histopathology. If the grade is higher grade 3, then the preoperative histopathology DNC and final surgical histopathology concordance is only 45%. So that's why frozen section facility, if available, is very important and useful in endometrial cancer. Histotype diagnosis does not consistently predict clinical outcome. Even a clear cell stage 1A endometrial CS sometimes is very good than a 1B endometrial CA. So prognostic separation therefore is unreliable and inaccurate just based on histotypes. So attributes for a meaningful diagnosis is to understand both by clinician and patients and clinical relevance, sensitive and specificity. So hence this cancer genomic atlas, TCG endometrial carcinoma came. Now this is the genomic chart profiling which has come, which distinguishedly identified endometrial cancer into four distinct group. One is Polay, ultra mutated, MSI, hyper mutated, copy number low endometrioid, copy number high which behaves like serous like. Okay, please remember this. I will explain you in the coming part of the talk over next time. Okay, next completion. So these are the four distinct criteria. They have four distinct prognostic area. Each one of them, the Kaplan-Meier curve you can look here, totally separates into distinguish pole best, P53 worst, copy number high worst, and they are identifiable easily. Okay, why this is important? If you take an endometrial cancer and if you either on IHC or on NGS, next generation sequencing, if you classify them into four distinct molecular, if you follow them, the overall survival changes. Pole, ultra mutated, doesn't matter, node positive, node negative, stage 1, stage 2, myometrial invasion, present, not present, FIGO, grade, all of them, almost 99 to 100% survival is there at 5 years. Next best is MSI, microsatellite instability, hyper mutated. This has got the second best prognosis. Then copy number low endometrioid variety has got the third best. Worst is copy number high serous likes. This has got worst. As I told you, 50% of the women are dead by 5 years. So molecular classification classifies distinctly into four. Okay, I will enumerate to you again. Now when you put back this old classification, type 1, type 2, we know that 70 to 80% are type 1, type 2 is 20%. Type 1, grade 1, endometrioid, type 2 are usually higher grade serous clear cell. Clinical behavior in type 1 is good, type 2 is aggressive. Type 1 occurs in young women, nulliparous or obese. Type 2 occurs even in an atrophic endometrium, multiparous, non-obese older women. Estrogen hormones are positive, estrogen receptor ERP are positive in type 1, type 2 is no. Pre-malignant lesions are not there, usually not there in type 2, but type 1 it could be atypical hyperplasia, atypical hyperplasia, and then it could present mutations. P10 KRAS are there in type 1, but P53 is there in type 2. Protective factors are there like OC pills in type 1, not protective in type 2. Caucasian race as type 1 and non-white. This is very important in exam. Now, based on the cancer genome atlas, we have pole mutated, MMR T type 2, NSM variety where P53 is wild, class 4 where P53 is mutated. So these are the four varieties. Now we will fit all of them into this particular area. What is Polay? It is unfortunately only in 5 to 15%. Remember, that is the best variety you have, and unfortunately it is only in 5 to 15%. It is a ultra mutated, more than 100 mutation. Histopathologically, usually it is endometrioid. There is a high TIL, that is a tumor infiltrating lymphocytes. High TIL is very good. It can be reported by a pathologist, gives an indirect indication of Polay. Of all the three things, identifying Polay is tough. Remember, MSI, MMR, P53, ERPR, HER2/neu can be analyzed on IHC, which is easy. Cost is less, 1 to 2,000. In 2 to 3 days you can do it. You don't need NGS. Polay mutation is the only one which cannot be identified on IHC. You need a NGS platform or a Sanger or a hotspot, which is expensive. Initially it used to be 40 to 50,000. Now in India it is routinely available at around 15,000-18,000 rupees now. Polay was tough. That's why we used to do MSI or MMR, P53, ERPR, HER2/neu on IHC, and if they were all like any abnormalities there, P53 is not mutated, then I used to ask Polay in intermediate group. Okay, so Pol is good. It cannot be done on IHC. It needs NGS, Sangers or hotspot. Usually it happens in low BMI, They are early stage, early onset. Even if they are node positive, no matter what grade, what stage, they don't need chemo radiation. Second one is DMMR. That is 20 to 30%. Quite a good number. If you see that, they actually constitutes the very high number of the group which comes in that. But the best one, as I told you, you is actually Polay. So if it is MSI hypermutated, where 10 to 100 mutations are found, it is usually endometrioid. It comes in high grade, but TIL is positive, but LVSI is there. Prognosis is intermediate. On IHC, MMR assay can be done. Higher BMI, it is usually associated with Lynch syndrome. So remember, Lynch syndrome, colorectal, gastric, pancreatic, uterine. So Lynch syndrome is quite common. You need to identify them. Next one is NSMP, where P53 is wild type, which happens in 30 to 40%. Copy number is less than 10. It is endometrioid variety, low grade, ERPR positive. Commas differentiation can be there. They also are intermediate. P53 can be identified by IHC in them, and all others are negative, and high BMI is present. The last one and the worst is total P53 mutated. They have very high copy P53 penetration, and their other histopathologies, high grade, TIL is negative, tumor infiltrating lymphocytes, very, very poor prognosis. P53 can be identified by IHC diagnostic test. Low BMI, thin patients, advanced age, late onset. So this is a very important way to understand. So there is an indirect way of analyzing, looking at TIL and based on IHC. Now I'll take one at a time. Now we'll see Polay mutation. Only 10% endometrioid, young woman, low stage, higher tumor grade doesn't matter, scattered tumor giant cell, prominent lymphocytic infiltrate. High mutation burden, more than 100. They are classified as high risk based on initially, but they are exceptionally good prognosis. Initially we thought it was high risk, but no. Now look at the right side Kaplan-Meier curve. If you have this Polay mutation present, whether you give RT, whether you give chemo or RT, practically all of them have a same survival. So this is one place where we don't give chemo. Remember this. Next we have the MMR. 20 to 25 to 30%. Majority are MLH1 promoter methylation. Higher grade, large number of TIL is positive. High prevalence of LVSI, but they respond very well to radiation. That's why, this is very important. If you have an MMR deficient, these patients respond very well to radiation. And if there are unfavorable factors based on the original clinico-pathological radiation, don't omit them because they benefit. Additional chemo does not improve prognosis. So, Polay, RT, chemo, no. MMR deficient, radiation, yes, chemo doesn't improve. Immune checkpoint inhibitor are used in recurrent cases. So you must understand where radiation, where neither of them, where chemo and where immune checkpoint inhibitor. Now if you see the serous-like variety, diagnosis is easy because, once you do Pol mutation and MMR, these are excluded. Then you look at P53 and then you also look, there could be another pathway which is HER2/neu or HRD. Remember, there are three factors, HRD, recombinant and then HRR. Now it is more of HRD now rather than HRR. There is one more trick of getting Polay. If you ask Polay mutation to pathological genomic lab, they charge very high, 60,000-70,000. But if you ask HRR is usually 20,000 rupees in India, and then Polay and P53 automatically comes in that. So it's important. If you want to save money, you can ask HRR, but you will know. But remember, HRD is more important. So there is another pathway which is HER2/neu pathway. If HER2/neu is positive and MSI is stable, immunotherapy. Why you need MSI? If MMR deficient, MSI instability, then immunotherapy, pembrolizumab or nivolumab helps. As of now in endometrial cancer. If none of them are there, but HER2/neu is positive, HER2/neu path also helps in advanced endometrial cancer. So P53 is very bad. That's why chemotherapy is required. So this is something which is very, very important, which I wanted you to see. So there are 4 distinct molecular subtype based on what I told, like ovarian cancer histotypes. MMR deficient, P53 Polay positive, MMRD positive pole, MMRD pole positive, P53, and this is how you can identify this particular group. Now we will look how we can approach based on the Paretic trials. So now if you look the Paretic 3 trial, how do you approach the management? First you see whether it is Polay mutated or not. If Polay is mutated, then straight away they fall into a good pathological, that is where it helps. Suppose pole is wild type, means not mutated, non-pathological Polay, then you look whether it is MMR deficient or proficient. If MMR is deficient, then it's a different variety. Then if MMR proficient, then you look whether P53 mutated or not mutated. So this is one way straight of approaching. I'll tell you how we can now look at the differencing variety of each one of them. So by current classification, most of them can be identified by IHC except the Polay. So morphology alone now doesn't distinguish any of them unless you do a molecular profiling. So this is a very good working horse. First you do Polay, wild or mutated. Mutated, very good, you don't have to worry about other. If it is wild type, then you look MMR. If MMR is proficient, then you look whether P53 mutated or wild type. So this is the algorithm. But because of the cost factor of all of the four, Polay is the most expensive to do the test. So we go normally the other way around. P53 is very easy to do, immediately. MSI, MMR and P53 very easy to do on IHC. Then we work retrograde in India to save money. Okay. So now this is how the whole genomic subclassification are. Pole ultra mutated, endometrioid, lower grade, KRAS mutated, P53 not, prognosis excellent. MSI hypermutated, copy number low MSS, they are intermediate prognostic. And copy number high, P53 mutated, very poor. So this is distinguished same in all of them. Best to worst. Best is Polay, worst is P53 mutated. So the other two are intermediated, unclassified is somewhere in between. Now when 410 cases of Paretic 3 trial were reclassified, reanalyzed. How does a new classification come, HSCC or FIGO? You bring a new classification, you open the whole database of the patients of the old trial where this many trial with this many molecular, you have actually the tissue banking done. You redo the test and then validate it. How did we validate it? Endometrial cancer, which were either grade 3, 1B or LVSI present or not, when they analyzed it, they found that in the Paretic 3 study tissue banking, if P53 was mutated, their survival at 5-year PFS was only 48%. Can you look at this? This is very, very important to understand. If they didn't receive chemo. If they received chemo, they moved to 59% versus 36%. RT alone 36%. Chemo added, improved from 36% to 59%, which means there is a distinct group of 53. When you look pole mutated, whether you gave RT or you don't give RT, you gave chemo or not, survival was 97 to 100% in Paretic trial. So that validates the concept of Polay mutation. When MMRD is there or NSMP is there, you can look that PFS is intermediate, so almost 2/3 are alive. And in cases MMRD, chemo didn't add benefit, but radiation had a local regional control. In NSM, RT versus chemo RT alone, then you can see that chemo plus RT had 80% benefit and RT alone 68. So here chemo also benefits in NSMP. So that means Paretic 3 data validated this, and rightfully this first molecular typing which we had, non-molecular typing as 2014 ESMO ESGO Estro consensus. Now in 2020, the ESGO Estro ESMP, even just now 2022 new guideline came. Now the molecular subclassification based on this is classified totally into stage 1 to Polay mutated, stage 1A, stage 1B. So you can look at it now. There is an integration that has happened. You can go back and read. As I tell, I can't spoon feed. You have to just take a screenshot of the slides, read and understand how and what changed in 2020 ESGO Estro ESP guideline compared to old based on this molecular profiling, which is very important to understand. So if it is Polay, nothing needs to be done. Then if pole A is wild type, and then you look at whether MMR is deficient, MMR is deficient or MSI is stable, then you look whether you need to add radiation or you need to add chemo, and whether it is P53, then stage, nothing matters, even stage 1A P53 would need treatment. So Polay mutation is low risk, which was previously considered as high risk or intermediate. P53 abnormal is high risk even without myometrial invasion. And the whole classification of treatment is like this. So P53, for all the stage, there can be a role of checkpoint inhibitors and PARP inhibitor. And as I told you, P53, all of them need both chemo radiation. MMR deficient, radiation is good, useful. NSMP, role of hormone therapy and chemo is there. Polay, no adjuvant. So this is a very important. This is a rainbow umbrella program coordinated by Paretic Consortium, which allotted endometrium into 4 internationally, academically sponsored trials, and this is the subtype and this is the treatment. Polay, nothing to be given. P53, radiation, chemo, both required. DMMR, radiation has a use. NSMP based on the stage 2, stage 3, chemo, radiation and hormone. So now this is how the whole classification has happened. Any myometrial invasion and P53, remember, don't have to be more than 50%. The new IGCS data which got presented in 2022 New York, which is now adapted, if there is a P53 mutation by IHC, it can also be identified on AGS. Any myometrial invasion didn't have to be more than 50%, they are high risk. Now that's why that old concept of myometrium less than 50, more than 50 is useful. So P53, any myometrial invasion didn't have to be more than 50% is high risk. They all need chemotherapy, radiotherapy. Very important to understand something which has changed. So when you look back the paper which got published recently in Lancet, Kosib et al. 2022, Promise to Promise 2. How this algorithm which I told how to do it. Usually you start with pole and come down to P53, but in India we do the other way around because of the cost factor. So when you looked at pole mutated, then MMR, then P53 abnormal EC, and then NSMP, DNA is extracted from the tumor. Next generation sequencing is done for Polay. Then you can do P53, it can also be replaced by IHC. Then MSI array is done and it is replaced by MMR by IHC now. In fact, they say that part that is more reliable. Only Polay is the one which you need. So now this is the new Promise trial. So how to test Polay? I will not bore you. As I told you, if you look at BAGP guidelines and BGCS guidelines published this year, April 2022, so this is the only test, unfortunately, it is by NGS and it is not by IHC. Okay, so integrate these two particular areas. So summary of molecular testing. Polay mutation has excellent prognosis. Portec 4A gave evidence and more evidence will come. Polay testing should be carried out in all non-low risk. See, suppose there is an intermediate group or high intermediate and you don't know chemo radiation to be given or not. See, if P53 is mutated, any myometrial invasion story is over. They need chemo radiation, no other testing is required. But if P53 is not mutated wild and then now they are falling down into intermediate, then Polay is something where you have to do. Polay should be done in non-low risk. And where you think there is a need for adjuvant chemo radiation, then you do Polay. If it is mutated, no chemo radiation. If Polay is wild type, then you look at DMMR. RT is required, no chemo. And then if P53 and DMMR is interplayed, then hormone, chemo and radiation is required. So this is in conclusion what I told, because the outcome is totally based on this. So intervention needs to be done based on this particular area. So now this is the new guideline which ESTRO has brought out, which also got refined. Stage 1A, any myometrial invasion, stage 1A, P53, all of them needs chemotherapy, radiotherapy, which is the most important thing. So this is the way to approach, I told you. People normally do Polay, pathological or non-pathological, then you do DMMR, then you do P53, but we look at the other way around, because so now in endometrial cancer, at least MMR P53 should be done, even if you don't do Polay, but it's available now extensively. So concise, ready to use treatment guideline now. Stage 1, if it is Polay, whatever be LVSI, whatever be grade, whatever be node status, no further treatment required. If it is stage 1A low grade, then MSI MMR status is important, no further treatment. Only brachy to be done if it is a FIGO grade 3 and stage 1A endometrioid variety LVSI negative. If it is stage 1A, no myometrial invasion, brachy alone. P53 abnormal non-endometrioid brachy is required. And if it is substantial LVSI, that is where brachy is required. External beam radiation needs to be added if you have a P53 mutation and any myometrial invasion which is available. In stage 2, if it is Polay mutated, observation for all grades, all histopathology. Stage 2, it needs radiation if it is not Polay wild type and then in NSMP and MMR deficient. If it is P53 mutated, external beam radiation and chemo is required. Stage 3, 4 all needs radiation and chemo. So the whole essence changes in stage 2 and stage 1. So this is very important to understand, where no treatment, brachy alone, EBRT with chemo and hormonal therapy. In conclusion, petition for adjuvant treatment in endometrial cancer is taken based originally on surgical and pathological, but now on molecular. The advent of molecular classification has revamped the risk stratification system. MMR P53, at least by IHC, should be adopted in low energy resource country. Polay by Sanger's or NGS testing doesn't appear to be feasible in all country, expensive. It can be done in intermediate group where you have to now take a decision of adjuvant treatment. Appropriate radiotherapy, vaginal brachytherapy alone or EBRT is mainstay of adjuvant treatment in intermediate and high intermediate. Remember, what did I say? Don't overtreat low risk, don't undertreat high risk. How do you overtreat low risk? By unnecessary doing lymphadenectomy when it is not required. Because you have not done a right staging, say SLNB or other, so you end up giving radiation without any benefit. How do you undertreat high risk? By just doing pelvic lymph node assessment, not assessing high paraotic sentinel node where you could miss node positive stage 3 which needs chemo radiation, or by not giving chemo in high risk group node positive because they are not adequately staged and not curing them. So don't overtreat low risk, don't undertreat high risk. Chemotherapy appropriately sequencing radiation as indicated by high risk endometrial cancer is very, very important for us. So that ends my talk. So what I will do is, let me now try to open and answer some of the questions. I know that it is not something easy, very tough particular topic, but I try to simplify it. It took a lot of time actually, to understand and then do this particular thing, not very easy to do. Okay, first Rakesh has asked, sir, is paraotic sampling needed in Polay? Now, how do you know it is Polay? This is something very important. I told you that Polay is very tough to do. You need Sanger's or NGS. Cost initially was 90,000. Now it has brought down to roughly 20-23. If you ask HRR, Polay comes in that. Now you can't do an endometrial biopsy, DNC, until I'll do Polay. I'll wait for it. Oh, Polay came mutated. Now I'm not going to do. No, ideally it is not required, but there is no way you can know that preoperatively, and we don't do that. So that's why currently the lymph node staging would be based on the clinico-pathological variety. That is, if it is FIGO, if more than 50% myometrial invasion on frozen section, not on MRI or this one. FIGO grade 3, we do that. Now almost the whole lymphadenectomy in endometrial cancer is replaced by ICG, Firefly, SLNB. So paraotic is not based on Polay. If you have that, you are lucky. Otherwise, paraotic assessment is mandatory. Next. Question, can there be a combination or mutation in single patient? I told you no. Based on the trial, they distinctly classify into 4. See, if you have combination of more than one, like I'll tell, P53 mutation is there. Straight away, it doesn't matter now. Because, now MSI or DMMR, none of them matter. They are all P53 mutated, muscle invasive, high risk. Matter is over. Now, Polay and P53. So, if you look at Polay mutated, that supersedes everything. So, there could be combination of more, but then the higher one straight away takes the precedence. So, this particular questions are there. How do we do in case there is a double classifier? So then P53 takes the precedence. P53 mutation with muscle invasion is totally changed. If Pol is totally mutated, P53 is absent, then it takes then the intermediate group. So then these two are the two spectrum. So that is the way totally it changes. Okay, I think I don't see any other question. Navneet Singhji, I think I answered all of them. Okay, Q&A, only one question. It's done. And chat box, I think I answered all of them. Okay, one more question has come just now. So remember, Paraotic assessment is required in all patients of endometrial CA by SLNB. If you don't have SLNB, then more than 50% muscle invasion, more than 2 centimeter, FIGO grade 3, it always needs paraiotic, because 4% isolated when pelvic node is negative, it is positive there. If you miss that, then you think it is stage 1, you don't give chemoradiation, all 2/3 are dead. And when pelvic node is positive, 69% to 73, high paraiotic, above the IMA, below the renal vein is positive. And in old classification, paraotic node positive required extended field RT or a chemotherapy. So that's why paraotic assessment in high risk is required. What about PCR testing for DMMR? You can do that. IHC is nowadays more easy. You can do both, either one of them. If you do PCR, then PCR is also one of the way. But NGS, they say, is more stable, or an IHC platform. Since frozen section final histopathology invasion can we do from MMI? Yeah. See, frozen section is better than preoperative DNC if you can do that, but it is expensive to do that. But difficult to do on a frozen section. Why you want to do MMI? Better do a good staging. There is no, nowadays everything is moved into ICG, SLNB, so less morbidity, but assess the paraiotic. Do we require pelvic lymph node sampling? Don't use the term sampling. There is nothing called sampling in oncology. Either you do nodes or you don't do it. You stage, you don't stage. You do sentinel lymph node or you do systematic pelvic paraiotic. Don't use the term sampling. What do you mean by sampling? I will remove one external iliac? No. I will remove one iliac? No. I will assess common iliac? No. Where is sampling defined in anywhere in the oncology? Even in axilla, please don't use the term sampling. There is no defined term as sampling in oncology. Sentinel, staging, non-staging. Comprehensive node clearance or staging. Only two phenomena. In staging, you do sentinel lymph node or not. That's it. So if you have an SLNB, do SLNB, that is staging. Or a comprehensive pelvic paraotic lymphadenectomy with high risk. So do we require to do systematic? As I told you, now in endometrial cancer, the whole staging in FIRES, as per the FIRES protocol, is you do ICG, SLNB. If you do ICG, SLNB, and then you manage the SLNB ICG, if frozen section is positive, most of the people then take it as high risk and do chemoradiation. There's an algorithm written in NCCN. Please go back and read. And if SLNB is negative, then no pelvic paraotic is required. But however, the survival data based on ICG, SLNB positive and not doing lymphadenectomy is not available. So even though most other institutions actually do SLNB, and if it is negative, they don't do anything. If it is positive, they give chemoradiation. In my institution, I do systematic pelvic paraotic only for that group, because there is no randomized control trial as of today where you have done an SLNB that has come positive. You don't do omit systematic lymphadenectomy, give chemoradiation versus surgery by chemoradiation. There is no RCT as of today. So there is no term called as sampling. Please don't do that. Can paraotic SLNB be missed if tumor is lower uterine? No, it will not be missed. It depends upon the type of the dye you give. In old time for SLNB, there was people used to think that I'll do histoscopy and inject. Then they used to give subserosal when they put laparoscope or robot. Now it is proved that if you give, in the cervix at 3 and 9 o'clock, 1.1 ml submucous and deep. The deep cervical stromal deep ICG will show paraotic. However, having said that, you may miss it. Nothing is 100%, 3% could be missed. But if you give a cervical deep stromal invasion, then paraotic is picked up well. So paraotic is missed. Good. I think all things have settled down. As I told you, everything has to come to an end. My job is not to spoon feed you. You are not a first standard students or second standard students. You need to, I can just guide you and stimulate your brain. You need to go understand. One more question has come suddenly. SLNB for frozen section, do we send? There is a, please read, Google and read, or you can go back and read CAP guideline for assessment of SLNB. CAP guideline for assessment of SLNB. Number one. If you do a systematic pelvic paratic lymphadenectomy, and if you do sentinel lymph node alone, you pick up 5% of extra node positive in SLNB group. If you do SLNB and if you do ultra sectioning by CAP guideline, what is CAP guideline? College of American Pathologists. The microtome of the frozen section or the microtome of the section, if you put to 2 micron, anything less than 2 mm is, it is a micrometastasis. Its significance is not same as macrometastasis. Anything less than 0.2 is an isolated tumor cluster. As of today, no prognostic significance. So it is classified separately. So if you set the microtome of the sectioning machine at 2, take a sectioning of the one node which is 6 to 7, both on other side, stain on both the sides and look at it. That is the ultra staging. If you do this, remember there is no IHC in this, no CK, no IHC, then you pick up 11 to 15% of extra node positive than systematic pelvic and paraotic. If you add IHC to that, because remember endometrial cancer is a epithelial cancer, so IHC CK, cytokeratin is positive in a lymph node which is from a endodermal origin. You don't get in lymph node, it is LCA positive, not CK. Presence of CK in a lymph node means there is an epithelial component, there is a metastasis. So if you add IHC to a lymph node and then upstage the SLNB, then 23% you identify positive. But IHC positive sentinel node has no prognostic significance as of today, so not a routine. So you must just do a ultra staging the way I told as per the CAP guidelines. So CAP guidelines says that a group of surgeon pathologist should do 10 to 20 sentinel lymph node with microtome set at 2 micron, and if your false negative rate is less than 5% at the end of 20 case, then you can do sentinel node. So ultra staging, yes. Ultra staging by IHC only for research purposes. Okay. Now, do you do paraotic for serous? All the serous, uterine papillary, MMMT and carcinosarcoma and metaplastic are staged like ovarian cancer, which means omental biopsy, peritoneal stripping, washing and pelvic paraotic lymph node dissections are done in that. Okay. So thank you very much, and that ends the topic. I am on time, and I hope I have simplified it. This is the best way you can understand. I have given algorithm. I have told where IHC is done, where NJS is done, what is an algorithm to do, why you should do, where no chemo RT is required, whatever be the stage, where chemo RT both is required, even if it is stage 1A, and where only RT is required, no role of chemo, where there is a role of hormone therapy and chemo. I have analyzed how to analyze and what is the at last data, and how you extrapolate in the Paretic, the new astro guidelines, where only brachy should be given, vaginal brachy VBT, where both is required, where chemo is required, hormone therapy. Thank you very much, and over to you, Navneet Singh.
Yeah, thank you very much, Professor Dr. Somashekhar, for the presentation, and thank you very much, trainees and faculty members, for joining.